Objective assessment of luminal diameter and distensibility indices by an impedance planimetry system before and after pneumatic dilation in gastric sleeve stenosis. Gastric sleeve stenosis, or GSS, occurs in up to 4% of patients following sleeve gastrectomy and with a rising prevalence given the increasing number of sleeve gastrectomies being performed. GSS can result from an anatomical stricture or twisting of the gastric lumen, leading to a functional obstruction, which most commonly occurs at the level of the gastric midbody or incisura. Presentation of GSS often varies depending on the severity of obstruction and may include symptoms such as reflux, dysphagia, nausea, vomiting, regurgitation, and/or inability to tolerate oral nutrition. Diagnostic criteria for GSS are lacking. Impedance planimetry may play a role in objective assessment of luminal diameter. The impedance planimetry system contains a balloon catheter that measures the cross-sectional area and pressure in a lumen. It is commonly used in the esophagus for assessment of achalasia. The balloon is 8 centimeters in length and filled with conduction fluid. It has 16 impedance sensors and 1 pressure sensor. The impedance planimetry system reports lumen distensibility and diameter. In this case presentation, we demonstrate the steps, technique, and utility of an impedance planimetry system as a diagnostic tool for gastric sleeve stenosis before and after therapeutic pneumatic dilation. GSS commonly leads to symptoms of obstruction, dysphagia, abdominal pain, and reflux. Serial endoscopic pneumatic dilation has been shown to treat the symptoms of GSS in 80% of patients. Impedance planimetry literature to date for use in GSS has been limited but exciting. Our previous work has demonstrated that impedance planimetry is a useful tool for defining the severity of GSS. Furthermore, our pilot study suggests it may have utility in predicting who will and will not respond to pneumatic dilation, thereby facilitating earlier surgical referral for those patients who continue to be symptomatic. Relative contraindications to use of an impedance planimetry system include active variceal bleeding and situations in which endoscopy cannot be completed. The equipment and preparation important for this procedure includes the endoscope, the impedance planimetry system, pneumatic dilation balloon, stiff guide wire, and fluoroscopy. This procedure is typically performed under general anesthesia. There is limited evidence of any adverse outcomes after impedance planimetry use. In this case, we present a 64-year-old female who underwent a laparoscopic sleeve gastrectomy 3 years prior. Her postoperative course was uncomplicated. She recalls subtle symptoms of nausea and reflux, which she attributed to her new anatomy, but overall felt well. 2 years later, her symptoms progressed and she developed persistent nausea, intermittent vomiting, regurgitation, and abdominal pain. A diagnostic upper endoscopy suggested the diagnosis of GSS. The decision was made to proceed with pneumatic dilation with the use of an impedance planimetry system for objective assessment of gastric luminal diameter and distensibility pre- and post-dilation. After advancement of the upper endoscope, you can see that the esophagus and proximal gastric lumen are filled with bilious fluid. A stenosis can be visualized at the level of the incisura. With considerable torquing of the upper endoscope, advancement into the gastric antrum is ultimately successful. Endoscopic evaluation of the duodenum is normal. The scope is withdrawn and preparation is made for impedance planimetry system catheter advancement. The device is advanced through the esophageal lumen and the balloon is centered across the incisura at the level of the gastric stenosis. The balloon is inflated to 40 milliliters and diameter and distensibility measurements are recorded. Here you can see the impedance planimetry system images as the balloon inflates. Placement of the balloon is confirmed while the impedance planimetry system images are recorded, as the central red region on the real-time figure corresponds to the area of stenosis visualized endoscopically. Once the measurements are recorded, the balloon is deflated and withdrawn. Preparations are then made for pneumatic balloon dilation. A stiff guide wire is then advanced under endoscopic and fluoroscopic guidance deeply into the duodenum. The scope is withdrawn and a 30 mm pneumatic balloon is advanced over this wire. The endoscope is then advanced alongside the pneumatic balloon to confirm placement spans between the gastroesophageal junction and the pylorus. Crossing either of these two regions may increase the risk of perforation. The balloon is inflated with a sphygmomanometer used to control the pressure within the balloon. As the balloon inflates, you begin to see ischemic appearing gastric tissue, suggestive of successful dilation. The goal is to reach a pressure per square inch, or PSI, of 20. This dilation is also visualized under fluoroscopy. The balloon is then deflated, and the wire and the balloon are removed. Repeat endoscopy confirms no perforation or bleeding. The impedance planimetry catheter is again advanced into the gastric lumen with the balloon centered at the level of the stenosis. Measurements are again taken using a 40 milliliter balloon. As you can see, the area of stenosis is reflected by the waist-like constriction, which is less severe following pneumatic dilation. The impedance planimetry system measurements are reported below. As you can see, the diameter and distensibility improved considerably after pneumatic dilation. The patient was discharged home the same day. The patient had considerable improvement of her symptoms, corresponding with the improved measurements obtained by the impedance planimetry system. She still experienced mild dysphagia and abdominal pain, so a repeat pneumatic dilation was performed 4 weeks later, again with improvement in the impedance planimetry measurements. She has remained symptom-free over 6 months following these procedures. In summary, impedance planimetry measurements may provide an objective assessment of luminal diameter and distensibility in GSS. Impedance planimetry could potentially be used as an adjunctive tool in diagnosis. It may be a useful tool to assess and evaluate response, in addition to predicting failures to balloon dilation in the treatment of GSS. Impedance planimetry systems are not available in all endoscopy units. It may be difficult to pass a catheter in severely tortuous anatomy. Further studies are required to determine definite gradients of normal versus abnormal measurements and utility in predicting treatment response.